access. In other words, we don't wait to see if they qualify for all the things, but the care is provided and assuming that they're going to qualify for Medicaid.
Others? Okay, right back here.
I wasn't sure if the parents really knew how to find them the healthcare resources. The intake person said that they needed to find a physician for their baby or pediatrician, and yet they just moved. What's the best way to go about that? And a lot of the scenarios are the same. It's people are told to do something, but they don't know how to do it. They don't have the tools to do it.
Because was this a family that had assets? Was something working well with this young couple? Job. What else? Two parents. What else? Communicating with each other. Loving towards that baby. Those are assets. It's really important that with all of our scenarios, no matter what goes on with our families, that we're not just having a deficit mode. We're looking at what are those strengths, who has those strengths, and how do we build upon those. You're so right about the information. What else can we, if we think about it from a system standpoint, what might have been some of the things in that particular WIC clinic that should have been readily available for that family? Medicaid enrollment materials, great. And also, as you just said, presumptive eligibility.
Physician referral, accept Medicaid too.
Yes. Who are the physicians in the area that accept Medicaid?
A list of community resources.
Yes, a list of community resources. Did we notice something? What about the exchange that Dad and the nurse had? It was in what?
Spanish.
So, what does that mean about resources? They need to be bilingual. Okay, good. Others? I'm wondering.
The nutrition issue, I think,
Yes.
was important for me, and the fact that she found trouble breastfeeding the infant, and then so I saw that the pediatrician was directing her to a resource for that, but I thought there should be more of a closer connection somehow.
What are some of the local resources for breastfeeding programs?
Mothers to mothers.
Mothers to mothers? What else?
Election week.
What?
Election week.
Yes. Also, MIHP programs, other places. Other things in that skit that stood out to you. Okay. What about the issue of, from a family dynamic, the young mother made a point? Yes.
It's like DHS never followed up. No one ever got a hold of DHS.
Yes, no one ever got a hold of DHS. Because who would have the information? Right, right. How many of you ever been in a WIC clinic or you sat in doctor's offices, right?
Yeah.
And you usually stuck there for how long?
Well, depends on the doctor.
Right, right. It depends on the doctor.
And if
Now,
you
if
have
I'm
a
out at
medical
Bloomfield
home.
Hills and I've got really,
You have a
ACE insurance, then I might be there 15 minutes beforehand and then I'm what? I'm seen. But if you're at a federally qualified health clinic,
No card? No
Oh,
Medicaid card? No
nope,
nothing?
you might as well have your headphones on, right? But if we have the headphones on and we're sitting there, if this is the clinic and there's TVs in the room and they're looking like these TVs, what does that suggest? Anyone? Thoughts? You'll be sitting there, and what else?
And they usually don't have clocks either, so that you can't see how much time has left.
There's a method to the madness, in other words.
They're not using the TVs for prevention. They're not using the
Yes.
resources.
How can we do a better job understanding that we have people, quite frankly, captive? How can we use that time in some meaningful ways to deliver information, build up people's resources, do them in multiple languages? How many of you have ever spent time in a waiting room of, say you're a provider and you've gone to either present information in different waiting rooms? Hands from anyone? Okay, good. We'll talk more about that. But before we move to any kind of summary, other points about this particular skit?
I think the way a person addresses you when you come, I'm already been sitting for a while, and then just come on, I'm gonna be already beat. I'm already angry, and I like to be addressed by my name, like, or follow me, acknowledge me that I've been sitting here, and not just, oh, you've been sitting here, oh, well, you're lucky that we're gonna see you. That really sets parents off.
It's a very, very good point. There was, and before we move into looking at maybe program issues and systems issues, I just want to open it up. You've seen 3 skits, and we've had a little bit of dialogue. Are there some other points that you think are useful to lift up from a single one, or maybe all 3? Anything that's striking people, interesting? Okay, go ahead.
The first initial contact, customer service, the first is crucial.
It means everything, doesn't it? How you're received when you walk in the door. Okay, good. There was another hand up.
With the first scenario, I did notice the doctor did not address the patient. They asked all the questions of the parent, but I think it's important to also ask questions of the patient. They should be able to answer questions about themselves. Don't talk at them, talk to them, and not about them like they're not sitting there.
Excellent point, because who ultimately is responsible for yourself as you grow? We need to be about empowering even children to be able to articulate how they feel and to feel comfortable in a doctor's office or in that environment. Very good point. Did you notice in the second skit where we had the doctor and we had a married couple, did you notice how they were spoken to, even with our WCHAP team? Were we missing anything? How did that doctor speak to that couple? Called them by their first names and never said Mr. and Mrs. It was almost an assumptiveness that they were what? Not married. So we have to watch those kinds of assumptions, because that happens a great deal. There's a new level of assumptiveness, and I shared it with the staff, where it's mind-boggling to me that people are asking you, well, do you work? So it's almost an assumptiveness. While we may have large unemployment, we still have employment. So there's almost a predisposition on the parts of those who are serving many in our community that they are not working or they are not married, and therefore respond to them differently. Any other observations? Roberta?
To piggyback on that, I mean, to ask, you know, when a doctor or a social worker or any professional introduces themselves to a parent, to say, hi, I'm Roberta Walker, what's your name, or how would you like to be addressed? And then you can bypass that whole not knowing how to address them or not. But you oftentimes, especially in doctors' offices, when you walk in, you get their name. And I, you know, as a parent, will often get, hi, Mom. And I always think, I'm not your mother. So asking the person how they'd like to be addressed kind of gets past that.
Great point, great point.
And I thought it was interesting, the first couple, there was no father.
Mm-hmm.
Second couple was a foster father. And the third, there were obviously a close relationship. He was very solicitous of his wife and or girlfriend. Well, you know, he gave 2 different names to the receptionist.
Right.
So we can't make an assumption whether they were married or not. We don't know. But I thought that, you know, the point is that with a medical home, the doctor and the staff would know, you know, who these people are. They would know a bit about their history. Would know, you know, oh, they just moved here from Mississippi, or you know, this is a foster family and they've got a lot of issues with DHS and trying to access information. I think the medical home model really helps the physician understand the whole dynamic, which is what's been missing in most of these scenarios. What is the dynamic going on?
And being responsive to that dynamic, being aware of it, by the same token being responsive to it. Vicki?
I think one of the things that happened with the second scenario, where he said he tried to call the doctor, and didn't get an answer. He left the room and go out and call, still didn't get an answer. But that happens a lot, you know, one for the whole thing, or call this number, dial this number, wait, put you on hold, disconnect, you know.
Yes.
So that's an issue too.
And is that a family issue or is that a systems issue? That's a huge systems issue. And in fact, I almost begun to think that that's being done purposely, where it says click number 3, hold for 2 minutes. Then music comes on, it says, you know, you have 1 more minute, and then next thing you know, it's dead. And that is happening, you know, consistently. Any other systems issues that come to mind? Kelly?
With the medical home, one of the whole ideas is that integration of care, the continuity of care. So it really means that you know the organizations that you're referring to, you can speak to the quality, and also that they're going to get back with you so that your primary care physician is aware of what's happened in that time frame. So that was sort of missing in terms of good referrals, but then not the link.
Not the link, not the link. Thank you. And we're going to talk more about making sure that as we're talking about terminology, that we all understand what that means. Because we tried to define a little bit what pediatric integrated healthcare was. We've done a little bit, thank you so much, both you and Jack spoke to some of the definitions of medical homeless.
I was thinking too, I think it was in the last skit where the individual told them to go out and call DHS, but if they were familiar with how it really worked, just calling them would not have worked. You know, there could be, you need an email, you need a mail, so them understanding how the system works would be important.
Good. So understanding the specifics of navigating this craziness that we call a healthcare system, let alone the whole human service system. Yeah.
I was struck with something that I think many professionals I work with do, including myself, is I start from my knowledge base in communicating with the family rather than from their knowledge base. You know, and the one that's really stuck out for me was talking about a panic attack. You know, that may not be something that people have common knowledge about. They may not know how that could affect breathing. And to really break it down, first of all, by talking about, I ruled out asthma, and here's why. You know, I don't think this is an asthma attack. Here's why I don't think it's an asthma attack. Here's some other explanations for the problems you're having, blah, blah, blah. So to really start at least checking out the other person's understanding, and then building on that understanding to explain why you're making the diagnosis you are or the referral that you're making. And I think that that's something that a lot of us professionals kind of just skip to what we know is the answer.
We don't do that, do we? We don't just get a little bit of information and then pop, this is what's wrong with you, this is what you got to do. And isn't that's absolutely critical, because that's one of the major pieces that's important for us to be aware of. There are inaccurate medications and interventions being prescribed because people didn't take the time to learn and then make it a detailed and appropriate diagnosis. Okay, Jeanette.
Well, that's a good observation. And in fact, I was thinking, unless I missed it, I didn't hear any of the physicians ask whether or not they had a primary care physician to do the follow-up, to see whether or not they can obtain those records so that they can follow the case further.
Thank you. Roberta?
I also never heard them say, what kind of questions do you have? Yes. So we impart our wisdom, but then don't give an opportunity for the person to ask.
Excellent points. Other things that we're missing.
There was one thing where they had the baby. And she was saying she was having some difficulties with breastfeeding, but she provided milk. But they didn't ask whether or not the baby had eaten that day. So that's very important too, because if they're traveling and trying to get to and fro and she couldn't feed them and she may have run out of milk, that would have been a question I would have asked. Has the baby eaten today? You know, to make sure that we would have something. You're in the WIC office and they do have access to formulas. So that would have been important.
Excellent point. Real good. Fun.
Another thing that I see is that a lot of people in one system assume that it's very easy for you to get in touch with the people in the other system. Like, well, all you have to do is call them. All you have to do is ask for the name. All you have to do is, and it's just not that easy, but they make assumptions that it is.
So access is not just an issue of being able to get an appointment. Access is even knowing what you have to do to get the information correctly. So there's multiple layers. Jason.
Hey, Jametta. I just have to say that Deja's case was a very perfect scenario in regards to cross-system barriers that need to be addressed. With Deja's case, it's a classic example of the lack of systems communicating with one another. For Deja, she was a foster child, or is a foster child, which means that she touched the court system first. She touched DHS. She became a temporary court ward or MCI ward. She was probably placed in a purchase of service agency like orchards or something like that by DHS. Then they contacted the foster family, asked them if they wanted the